this innovative technique. The number one, we have replaced the trocar and protective sleeve of a special instrument set with the trocar and protective sleeve of PFN A2 set, which is present in our OT. And number two, we have eliminated the jig portion of the special instrument set and did both proximal as well as distal locking by freehand technique. And number three, we have added a color-coded tibial and extractor or more improved version of the color-coded tibial and extractor for RCT nail introducer compositioner to introduce the nail inside the intermedullary canal in proper position. So these three changes makes this innovative technique as a very, very cost-effective way of doing suprapatellar nailing of tibia. So friends, this is not a Jogaru technique. This has very strong mathematical or scientific basis. After jumping so many steps of mathematical equation, we have come to know that the success of interlocking nailing is equal to K into C into P into Z. Whereas K is the expertise in the art of the freehand technique of locking, whereas the C, P and Z are the respectively the availability of the C arm in your OT and protective sleeve in your special instrument set and jig in your special instrument set. If you increase the value of K to such an extent that the Z becomes zero, that is dependence on the jig becomes zero, this creates a scenario where the surgeon has mastered the freehand technique of locking and can perform both proximal as well as distal locking without the jig. So this is the mathematical basis. We conducted a study between March 20 to March 22 on 100 cases of non-articular fracture of the tibia done by Dr. Thakur innovative technique of suprapatellar nailing of tibia. So along with the other instruments, we had two pilot instruments. Number one, a color-coded tibial and extractor, which is the present in intrapatellar nailing set, and a more improved version of the color-coded tibial and extractor called RCT nail introducer compositioner to introduce the nail. This is the skin incision. You can see the transverse incision has been given, but you can give vertical incision also. And this is the innovative part of this innovative. Second picture shows the innovative part of this innovative technique, the introduction of the trocar and protective sleeve from PFN A2 set inside the retropatellar space. And the third picture shows the innovative part of this innovative technique, that is the proximal locking by freehand technique. So after making a hole just medial to the lateral tibial spine, we introduce a malleable guide wire. After percutaneous reduction of the fracture with the percutaneous forceps, and after serial reading, we mounted a appropriate size nail over the color-coded tibial and extractor or RCT nail introducer compositioner, and finally we introduced the proximal as well as distal locking by freehand technique. So this is the flow diagram, nothing to repeat it again, and this is the post-operative follow-up steps. Again, you all are aware of this. This is same as the interpatellar nailing of tibia. No patient complain of knee pain in our series. All patients get full range of movement in our series by 16 weeks. At final follow-up, 84 cases found excellent results, whereas 30 had good results, whereas 2 had subacute infection at the screw site and 1 had infected non-union. The average time of union was 80 plus minus 10 minutes, whereas average fluoroscopy time was 38.5 plus minus 6.5 seconds. All patients followed 2, 3, 6, 8 and 12 weeks, and the average time of the union was 8 weeks post-surgery, whereas complete union occurred by 12 weeks in all our cases. These are the few cases, clinical and radiological pictures of the few cases done by Dr. Thakur innovative technique of suprapatellar nailing of tibia. So the number of studies done on this innovative technique is small. I think this is the only study done by me, although good number of patients were included. The study was not comparative with the standard technique, so a status of arteries over the pipeline nephropia was not evaluated in this study. Those furthermore studies required to compare this innovative technique. We had a high-tech presentation in IOACON and found a space in International Journal of Orthopedic Sciences. You can see, and this is a video we don't have time to show you. So the take-home message is this technique would prove a boon for small and medium-class hospitals situated in BSC, Great Town, in India, and poor countries like Bhutan, Nepal, and Bangladesh. where the allocation towards the health is very, very low. So this could prove also a very useful technique for Ayushman Bharat Yojana, which is the dream project of our Prime Minister, Shri Narendra Modi. Thank you very much for patient hearing.
Save time creating content and generate a high-quality clone of your voice with 11 Labs. Change the way you record podcasts, voiceovers, and branded content with the #1 AI-powered voice-generating technology. Stop searching for the perfect voice and stop wasting time re-recording take after take. Try 11 Labs for free and start elevating your content today.
The traditional teaching that the 99.99% of these cases unites without any significant deformity and without any significant functional impairment. But later on, it was found that there are severely distressed fractures, about 15% of cases require surgical treatment either in the form of tense snelling or the internal open reduction and internal fixation with plating. So let us come to our main topic, that is tense snelling is unlike preservative management. It provides stable fixation and early mobilization and reduces the risk of non-immune and mal-immune. Tense is less invasive, resulting in a smaller incision, reduced soft tissue damage and fewer potential complications, making it an attractive option for managing distress fracture of the clavicle. So we conducted a study between 25 cases of clavicle fracture, mid-third fracture, all were simple distress fracture according to AO classification 15D1 and 15D2. The age of the patient was 16 to 48 years. No comorbidity was found in our study group. So all patients treated by titanium elastic snelling in my hospital. So the mode of trauma, road traffic accident was the main mode of the trauma, whereas fall from height and fall on outstretched hand was the other mode of the trauma. So these are the typical mode of injury, the fall on the shoulder to protect the head injury in the road traffic accident. This picture is taken from AI. And this is a typical clinical presentation. A bump at the site of the fracture and the skin appears as if the fragment will penetrate the skin. And this is the radiological typical presentation, more than 2.5 centimeter displacement, and the Z type of condition are the radiological indication for the surgical treatment, either in the form of tense or internal fixation with the plate and the screw. So these are the already explained. The simple fracture were taken into consideration. Distressed simple fractures are spiral or oblique or transverse or short oblique between D1 and D2. The patient tries to find a affected lip elevated and the arm are hanging outside the table so that we can facilitate the abduction and external rotation at the shoulder to facilitate the abduction of the fracture by closed knee. The incision, a small incision, has a transverse or longitudinal incision about 1 to 1.5 centimeters, just lateral to the sternoclavicular joint is given. Adapter making an incision, we make a hole with the help of drill bit, and then we make this hole continuous with the intramedullary canal of the clavicle. But this is very, very crucial step. One should take his own time and use tips and tricks to do this step, because the heart and lungs, like vital structures, are waiting for an instrument to escape. So after making the hole, we did tense snelling after close reduction or mini incision reduction. So the immediate post of pain management and immobilization, after 2 weeks we did suture removal, at 6 weeks radiographic assessment of the fracture area, and 12 weeks the functional assessment, and if required the implant removal was done. And the operative time was 30 to 60 minutes, whereas fluoroscopic time was 10 to 30 seconds, and the blood loss was 20 to 50 ml in all our cases. So the excellent result in 76% of cases, whereas 16% cases were good results, and fair and poor results were 4% each in our study group. The complications are nail bypass, superficial infection, and the malunion, each were 4%, whereas hardware irritation was 8% in our study group. And these are the big cases. You can see that 15B1 fracture treated by titanium elastic netting, beautiful surgery without use of any instrument. The reduction has been done only by shoulder movement, external rotation and abduction, and with the help of the thumb and index finger. The beautiful surgery. And this is another case, yet another case of 15B1 fracture treated by titanium elastic netting, yet another case of 15B1 fracture treated by titanium elastic netting. These are the 15B2 fracture, this is 15B3 fracture treated by titanium elastic netting. Ideally, it should be treated by open reduction and internal fixation, but we did tense netting, and you can see that 6 months follow-up, the beautiful neurological union. This is the functional result. You can see time is there. So the limitation of this surgery is a small number of cases included in this case, in this study. So the short follow-up period and retrospective design. So a study with large number of population and long duration of follow-up and prospective study is required to establish this modality of treatment as an attractive option for the treatment of distress fracture of the take-home message is tense netting is effective for the clinical fracture with good to excellent outcomes, minimum complication if the patient are selected properly and the technique is performed properly. The further studies are needed to confirm the long-term efficacy of this. This work published in International Journal of Orthopedic Science. The road traffic accident was the mechanism of injury, clinical presentation, severe pain and deformity, and inability to bear the weight on the right side, whereas the left side he had a Karachi fracture. So the challenge was the patient presented with significant surgical burden and the major long bone fracture concurrent with the complex forearm fracture and dislocation, which is called the Karachi fracture and dislocation. And this is the X-ray of the femur, the sharp femur, the mid-cut fracture of a 17-year-old gentleman, and the forearm Karachi fracture, severely displaced fracture. Inner canal, it was narrow, so the nailing was difficult. The standard treatment is nailing. And ideal treatment for this Karachi fracture is the plating, but I opted nailing, although it was difficult nailing in the both fracture and the slight distraction, the tense nailing for Karachi fracture, and this is not reported in any literature for such a severely displaced fracture. The tense nailing should be considered. In fact, there is no literature present for the tense nailing for this type of Karachi fracture. So we did for the minimally, because it is minimally invasive, and periosteal and endosteal blood supply are maintained in both fracture, and the interlocking nailing was done in the sharp femur, and only 9 millimeter nail could be negotiated because the narrow medullary canal. So there is slight distraction, as you can see in this picture, but we did locking. It was difficult nailing, So the goal was to provide sufficient stability for early mobilization despite of an anatomical constraint, and implant was 9 millimeter nail and technique was minimally invasive, and whereas in this left radius, the Gallagher fracture, we did 10 snelling. In this case also, the 2 millimeter 10 snell was used. Usually you use the 2.5 millimeter 10 snell, but we use 2 millimeter 10 snell. Still there is distraction at the fracture site. So this was the problem with this due to the narrow canal, but this is a 6-month follow-up. You can see I sent this X-ray in Indian Orthopedic Research Group, IORG, and they told to revise this case, bone grafting and plating for Gallagher fracture. So, but I left it and wait for it. This is the 8-month follow-up. Still there was better union than 6 months, but this was not hypertrophic. This is 11 months. You can see. So after waiting 11 months, the union is complete in both the fracture. The secondary colors have been formed. It was not hypertrophic. No, the union, secondary union. Taking place, although it was delayed union, but this is the functional result. You can see that supination, pronation, and wrist movement, flexion and extension all are present, and the tense snelling is provides sufficient stability for secondary union even in length critical fractures because the narrow canal and the length should be maintained to, and DR UJ should be reduced properly. Followed throughout the 11 months for this maintenance of the length and DRGO maintenance. And advantages of this minimally invasive approach for Gallagher fracture and femur is minimally invasive and reduce operative time and significantly minimize minimum blood loss. And this is the conclusion that the TENS is viable, effective alternative for plating for the complex forearm injury. The successful management of this double fractures case confirms that interlocking nailing of femur and TENS aids higher union rates and excellent functional outcomes. This approach should be considered for Gallagher fracture in adult after further studies, because I think this is the first case in severe Gallagher fracture. I did TENS. So this case was published in International Journal of Orthopedic Sciences.
वरुण, तुम सचमुच में वानी से प्यार करने लगे हो? तुम मुझे धोखा दे रहे हो? मम्मा, देखो, वरुण बिल्कुल बदल चुका है। अब ये अकेला ही सारी दौलत हड़पना चाहता है।
मेरे दिमाग की ना बैंड बन बचाओ तुम। यही कहीं ना पटक दूंगा तुमको मैं। बेवकूफ हो, दिमाग कम है तुम्हारा।
ऐसे और शोज देखने के लिए डाउनलोड करें Amazon MX फटाफट और देखें सभी शोज बिना किसी सब्सक्रिप्शन के बिल्कुल फ्री।
Stable fixation and earlier mobilization and reduces the risk of non-union and malunion. Hence, is less invasive, resulting in smaller incision. Conducted a study between March 2020 to March 2025 on 25 cases of the displaced fracture of the clavicle. The age of the patient was 16 to 48 years, and no comorbidity was found in our study group. All patients treated with titanium elastic nerve. So the road traffic accident was the main mode of the trauma, whereas the fall from height and the fall on the outstretched hand was the other mode of the trauma. So the typical mode of the trauma, this picture is taken from the AI, and this is the fall on the shoulder to protect the head injury in mode of trauma. And this is the typical presentation, a bump at the fracture site, and the skin appears as if the skin will penetrate the fragment will penetrate the skin. So, and this is the typical radiological picture. You can see the severely displaced fracture, more than 2.5 centimeter, a jet type of fracture, that type of communicated fracture, and the other indication for surgical treatment is the floating shoulder. So these are the typical presentation as well as the radiological presentation and the mode of the injury. And we included the simple fracture only, 15B1 and 15B2 according to KO classification. The 15B1 is a spiral and oblique, whereas 15B2 is a transverse and short fracture. So the patient lies supine with affected limb elevated and hanging outside the table so that the reduction can be done by doing abduction and external rotation of the shoulder. So incision is 1.5 centimeter lateral to the sternoclavicular joint, and after making incision, we make a hole with the help of the drill bit or the bone out. But this is a crucial step. One should be very, very cautious because the heart and the lungs are like vital structures are waiting for your instruments to escape. So this is a very crucial step, and then make this hole continuous with the intramedullary canal of the clavicle, and then we did close reduction or mini incision reduction, and then titanium elastic nerve was done after reduction of the fracture. So the post-op protocol or immediate post-op, we did pain management and immobilization of the limb at the 2 weeks, the wound inspection and the suture removal at the 6 weeks, the radiological follow-up for the fracture healing, and by 12 weeks, the functional assessment of the fracture healing, and finally, if required, the implant was removed at the 12 weeks. The 6-month final follow-up of the 20 to 50 ml in all our cases. So the post-operative observation, excellent results, 76% of patients, whereas the good results were found in 60% of cases, whereas the 4% was the figure for the fair as well as the poor results. So the complications, the nail bite count, superficial infection, and malunion each had 4% figure, and the hardware irritation was 8% in all our cases. These are few cases. The radiological as well as clinical picture, as you can see, this is 15B1 fracture, treated by titanium elastic nerve, the post-operative case, and the beautiful surgery has been done You can see the one ST surgery, no instrument was used to reduce the fracture. Only the thumb and the index finger was used to reduce the fracture, and abduction and external rotation of the shoulder was used to reduce the fracture. But this does not happen always. Many times we require the mini open reduction of the fracture. So this is another case we did. The 15B1 fracture treated by titanium elastic welding. You can see the 6-month follow-up, the beautiful union, the secondary union. There are 2 bumps in the clinical picture. You can see at the fracture site, there is secondary callus formation. 1 bump is due to secondary callus formation, and other at the entry site, you can see that there is hardware from this. So this is another case of the mid-third fracture treated by titanium elastic welding. Yet another case, 15B1 fracture treated by titanium elastic welding. Yet another case of 15B2 fracture treated by titanium elastic welding. And this is again 15B2 fracture treated by titanium elastic welding. And this is 15B3 fracture. Ideally, it should be treated open reduction and internal fixation with the plate and screw. But we did titanium elastic welding in this case also. And you can see that the beautiful union of the fractures at the 6-month follow-up period. So this is the functional result. And the limitation of this surgery, a number of cases included in this study was small and the short period of follow-up, and this is the retrospective duration, and a prospective study is required to establish this treatment as the attractive modality of the treatment for the mid-third fracture of the clavicle. So the take-home message is TENS snelling is effective for the clavicle fracture with excellent results, the minimum complication with properly selected patient and properly technique performed. So the further studies are needed to confirm the long-term efficacy of this modality of treatment. So thank you very much for your patience here.
ट्रिंग ट्रिंग।
हेलो,
हम तो हर बाबूजी के बचपन के दोस्त चतुर चाचा हैं।
प्रणाम चाचा जी।
उनका से बेटा 5,000 ले रही, अब ही तोरा के ट्रांसफर कहीं यहाँ बेटा, बाकी गलती से 50 चल गिल बा। पेमेंट मैसेज चेक कर ला बेटा, बाकी 45 हमरा के लौटा दो।
राउर मैसेज बाद में, पहले अपन बैंक अकाउंट तक चेक कर ली। अरे मुंह रखना है हम
सब। बस यूपीआई कहेला कि वो नकली पेमेंट के मैसेज भेज के पैसा वापस मांगे तो ओकरा से कह दी हम मुरुख ना।
ये फ्रैक्चर है टिबिया का, कई भागों में विभक्त है और इसे डॉक्टर ठाकुर इनोवेटिव टेक्निक ऑफ सुप्रापेटलर नेलिंग ऑफ टिबिया के द्वारा ऑपरेशन किया जा रहा है। इस वीडियो में देख सकते हैं कि गाइड वायर को डाला जा रहा है और गाइड वायर फ्रैक्चर रिडक्शन के बाद परक्यूटेनियस फोर्सेप्स के द्वारा बिना चीरा लगाए रिडक्शन फोर्सेप्स के द्वारा उसे रिड्यूस किया जा रहा है। और रिडक्शन के बाद मैल्लेबल गाइड वायर को सीआर के मदद से डाला जा रहा है और उसके बाद उसे मेडुलरी कैनाल को रीम किया जा रहा है और रीम करने के बाद
mandi sekali. Baca naik kakek pun balik barang ki.
मेडुलरी कैनाल को रीम किया जा रहा है और रीम करने के बाद नेल को गाइड वायर के सहारे सीआर के मदद से फ्रैक्चर को रिड्यूस पोजीशन में रखते हुए नेल को डाला जा रहा है। एक उचित साइज के नेल को सेलेक्ट करने के बाद उसे डाला जा रहा है। फ्रैक्चर रिडक्शन परक्यूटेनियस रिडक्शन फोर्सेप्स के द्वारा किया गया है। और अब नेल को डाला जा रहा है। हम नेल को फाइनली लोअर एंड ऑफ द मेडुलरी कैनाल डालने के बाद उसे अपर फ्रैगमेंट और लोअर फ्रैगमेंट को लॉक किया जाएगा। आप देख सकते हैं कि किस तरह से फ्रैक्चर का रिडक्शन हुआ है। ये है RCT नेल इंट्रोड्यूसर कंपोजिशनर, जिसके द्वारा नेल को डाला गया है और अपर और लोअर फ्रैगमेंट दोनों को फ्री हैंड टेक्निक से CR की मदद से गोल करने के बाद होल को गोल करने के बाद इस तरह से CR को एडजस्ट किया जाता है कि होल गोल दिखे और उसके बाद उसे ड्रिल करने के बाद उचित साइज का स्क्रू डाला जाता है। देखिए बिल्कुल गोल दिख रहा है अपर फ्रैगमेंट का दोनों होल और उसके बाद स्क्रू डाला गया है। गोल दिख रहा है। स्क्रू डाला जा रहा है। अपर फ्रैगमेंट के लोअर होल में डाला जा रहा है। फाइनली दोनों स्क्रू को उचित साइज के स्क्रू को अपर फ्रैगमेंट में लॉक कर दिया गया है नेल को। और अब लोअर फ्रैगमेंट के एंट्रोपोस्टेरियर जो होल है उसको गोल किया गया है। इस तरह से CR को एडजस्ट किया जाता है कि वो गोल दिखे। और अब एंट्रोपोस्टेरियर स्क्रू को डाल दिया गया है, जैसा कि आप पिक्चर में देख सकते हैं। और देखिए अब मेडियोलैटरल होल है वो गोल कर दिया गया है। इस तरह से CR को एडजस्ट किया गया है। और अब मेडियोलैटरल स्क्रू को भी डाला जा रहा है। ये मेडियोलैटरल स्क्रू डाल दिया गया है। और एक लंबा सा स्क्रू जो आप देख रहे हैं वो एंट्रोमेडियल स्क्रू है। ये तीनों स्क्रू लोअर फ्रैगमेंट में दिख रहे हैं। इस तरह से लॉक किया गया है बिना चीरा लगाए, छोटा छोटा चीरा जस्ट स्क्रू घुसाने के लिए रॉड में। और ये फ्रैगमेंट फ्रैक्चर है, आप देख सकते हैं कितना बढ़िया रिडक्शन हुआ है। 3 भाग में टूटा हुआ था। ये 3 लोअर फ्रैगमेंट का स्क्रू है, आप देख सकते हैं कितना बढ़िया अपर फ्रैगमेंट का स्क्रू है। ये RCT नेल इंट्रोड्यूसर कंपोजिशनर के द्वारा डाला।
Hello friends, today I am going to give a demo of interlocking nailing in fracture shaft femur lower third in a 72 years old female. This patient sustained this injury due to fall on the ground. Usually this fracture occurs due to high velocity trauma in young adults, either due to road traffic accident or fall from height. But in old age, this may happen in a trivial trauma due to fall on the ground. So let us come to the demo of this surgery. This is the X-ray of the same patient having lower third short oblique type of fracture of the sharp femur. As you can see, in the other limb, the patient has been operated, that is interlocking nailing has been done 4 years back for the fracture of the sharp femur. So this time the patient had come to me for the lower third fracture of the sharp femur for other limb. So let us come to the surgery. First of all, I will make an incision just above the greater trochanter, about 2 to 2.5 centimeter diameter, and then after blood dissection of the tissues, I am introducing a bone out just medial to the greater trochanter in the piriform fossa in APU. As you can see in the CR picture, and in lateral view, it is at the junction of the anterior 2/3 and posterior 1/3 of the greater trochanter. As you can see in the CR picture, I am hammering the bone out inside the intramedullary canal so that it can enter in selected exact entry point. And this is the lateral view. You can see that it is at the junction of the anterior 2/3 and posterior 1/3. You can see in the picture and epi view, this is the lateral view, this is the epi view, and this is the lateral view. Again, I have focused to confirm the entry point. And finally, after converting in the CR picture the correct entry point, I am introducing by a screen movement of the CR, and you can see that this is the epi view. It has gone in correct position, and in lateral view also it has gone in correct position. That is at the point of the anterior 2/3, at the junction of the anterior 2/3 and posterior 1/3 of the greater trochanter. So after confirming it, I am going to introduce still I am introducing the bone out inside the intramedullary canal, and finally a 2.5 millimeter guide wire is being introduced inside the intramedullary canal, just lateral to the bone out, which has been pulled out to make a space in the lateral part of the bone out to introduce the guide wire. And finally, after introducing the guide wire, we removed this bone out, and then after reduction of the fracture, with the help of the F tools, my assistant is holding this fracture in proper position, and the guide wire has been introduced in the distal fragment. And after introduction of the guide wire, we are going to ream the medullary canal with the help of 9 millimeter reamer, and it is being reamed with 9 millimeter reamer, hand reamer. And it has crossed the fracture, and my assistant is keeping the fracture in reduced position throughout the nailing process with the help of the F tool. During reaming process also, it is kept in reduced position, otherwise there may be maladjustment of the fracture. And I am doing reaming with a 10 millimeter reamer, and still my assistant is keeping the fracture in reduced position, and I am confirming on the CR whether the fracture is in reduced position or not. And this is in reduced position, slightly distracted, but in reduced position, enable you, and also in lateral view. This is the oblique view. And after performing in the CR, in both view, we did reaming up to the lower end of the femur, and finally we reamed this fracture with the help of power ream of 11 millimeter. Because the patient is old one, so reaming is easy. It is just to measure the size of the intramedullary canal, the diameter of the intramedullary canal, so what size of the nail should be introduced so that it can fit in the intramedullary canal. The fitting nail can be introduced. So this is the purpose of reaming, because the patient is old-bone osteoporotic. Throughout the nailing process, reaming process and nailing process, the fracture is kept in reduced position by my assistant, and the fracture has been reamed up to the upper end of the patella, as you can see in the CR picture. can see the CR picture. It is reduced, although they are slightly distracted, but in reduced position. And finally, it has reached up to the lower end of the femur. And now I am measuring the size of the nail with the help of the CR. And after selecting the proper size of the nail, I have mounted a 10 millimeter, a 11 millimeter, sorry, 11 millimeter nail on cheek. And finally, I am hammering the nail inside the intramedullary canal and keeping the fracture in reduced position with the help of my assistant, so that the malalignment can be prevented. And finally, I have introduced the appropriate size nail up to the upper cone of the patella. It is good position, the fracture is reduced in both view, in the oblique view and left view and lateral view. And then I will remove the guide wire before proximal locking, and now I am doing proximal locking after the removal of the guide wire. So you must keep in mind that before locking you have to remove the guide wire. And I am doing proximal locking. The proximal hole in the proximal fragment the near cortex is perforated with the help of 2.5 millimeter K wire, and the distant cortex is drilled with 3.2 millimeter drill bit. And finally, we select the proper size 5 millimeter screw for proximal locking, and I am still making a hole in the distal fragment, distal cortex, and now I am tightening the screw, the second screw in the proximal fragment. in the CR picture. The proper size screw has been tightened in proper position, and it is confirmed that it is inside the hole in both AP and lateral view. And now I will do the distal locking by freehand technique. I will make the hole circular after adjusting the CR in lateral position, and I am tightening the screw after drilling with 3.2 millimeter drill bit. As you can see in this picture, and both the screws have been tightened and confirmed in AP and lateral view. The size of the screw is confirmed in the AP view, and whether it is inside the hole or not, it is confirmed in lateral view. The size of the screw is slightly larger than it should be, but it was accepted because the effect of anesthesia was wearing off. So it was accepted. And you can see that both in AP and lateral view, the both proximal as well as the distal screw are in place and in proper position. And now I am going to close the wound after forceful wash of the wound so that all the. Now I am closing the wound after forceful wash of the wound. Now the wound has been closed. And my surgery is over. So thank you to my assistant, my anesthetist, and all the supporting staff for successful surgery of this 72 years old female for the fracture sharp femur, which had been operated on the other side elsewhere 4 years back. So this is on the whole a successful and well-executed surgery. Thank you. Hello friends, I am Dr. RCT Ortho, orthopedic surgeon, Chhapra, Bihar. Today I will give a demo of PFN surgery for an osteoporotic patient for intertrochanteric fracture of the femur. The design of the spiral blade provides a stable fixation of this fracture, and you can make mobile our patient. So today let us come to the surgery. This is the X-ray of 72 years male having osteoporosis with a fracture of the intertrochanteric unstable type. And this is the post-operative X-ray of the same patient, and now I am going to start my surgery. The skin incision, before the skin incision, I will draw a line from anterior superior iliac spine down to the table, and another line from the tip of the greater trochanter towards this first line, and the point of bisection of these two lines is the point of incision for this surgery. So I am making an incision at by these bisecting points where the two lines bisect. So I am giving incision
about 2 centimeter, as you can see in the picture. So I am feeling the correct point of entry. It should be at the junction of the anterior 2/3 and posterior 1/3 in lateral view, and in epi view it is just medial to the greater trochanter in the piriform fossa. So I am feeling with my fingers the correct entry point. So after feeling this, I am confirming, I am introducing a bone out at the correct point selected, and then I am confirming this whether this bone owl is entering at correct selected point or not in CR picture. So I am introducing the owl in correct position after confirming the entry point in CR picture, both in epi and lateral view. So this is the epi view. It is entering in proper selected position, and this is inside the intramedullary canal in correct position going medially in epi view, and this is hammered if it is in place inside the intramedullary canal in proper position, confirming in both epi and lateral view. And then I will pull this bone out for 2 centimeter to introduce the guide wire. The depression or groove present in the lateral side will guide this guide wire inside the hole, and the guide wire is entering inside the intramedullary canal along the depression or groove present laterally in the owl. So it is inside the intramedullary canal, well placed in epi view. And now I will remove the owl. So I have removed the owl, and I'm doing reading of the medullary canal. In the osteoporotic patient, the reading is not required. This is for the measuring the size of the intramedullary canal, diameter of the intramedullary canal, to select the correct size of the PFN to nail. So, but this is for measuring the intramedullary canal, and I am reading by number 10 and then number 11. remove, and the size is 11 millimeter diameter PFN nail selected. And then I am reaming with a 15 millimeter reamer because the upper part of the nail is about 15 millimeter diameter. So I am reaming this, and my assistant is the neck of the femur. And I'm confirming it whether it has gone in center position in both guide wire. I am introducing, just perforating making a dimple of distal screw. It has been introduced. Thank you everybody. My anesthetist, my assistant, my supporting staff. I think this is the well-executed strategy for a old osteoporotic patient, for unstable type of interconnective fracture. We can make this patient mobile from second post-operative pain, which is usually required. Although this was not a very displaced fracture, but to make the patient mobile, we planned this surgery for this patient. Thank you everybody.
Hello friends, I am Dr. RCT Ortho, orthopedic surgeon, Chhapra, Bihar. Today I am going to present my innovative work named Dr. Thakur Innovative Technique of Suprapatellar Nailing of Tibia. Tibial fractures are most common among the long bone fractures in human body. About 20 of a technique, but this can be lessened by gaining more and more experience in freehand technique for locking proximal and distal tibia. Thank you.
The number one myth is interlocking nailing of humerus will severely impair the shoulder function due to rotator cuff damage. The reality is, with proper technique and entry point, the rotator cuff damage can be minimized and shoulder function can be preserved. So the myth number two is there is other chance of radial nerve injury as it is a complication for the interlocking nailing of humerus. And it is not a complication for the open reduction and internal fixation for plating. So it is, yes, it is, there is risk of radial nerve injury when the fracture is at the spinal root. There is chance of the radial nerve injury, but in the rest of the part, if the fracture is in the rest of the part of the humerus, there is minimum chance of the radial nerve injury when the instruments like the guide wire, reamer, and the nail is introduced after proper reduction of the fracture in the distal fragment. Both AP and lateral view, the fracture is reduced properly. Only then these instruments are introduced inside the distal fragment. And don't allow your instrument to wander inside the soft tissue. So these are the two myths which is associated with interlocking nailing of humerus, and other two controversies whether which position of the patient should be used for the interlocking nailing of humerus. There are three positions. Number one, supine position. When it is used, it is comfortable for the anesthesia point of view as well as the surgeons. But if the distal locking, which is done by freehand technique, is slightly difficult and tricky because the anterior surface of the distal part of the humerus is triangular. So finding the entry point for the distal locking
is slightly difficult because slitting of the disc bit or TMI. So it should be an angle, it should be produced at angle, and then it should be kept in a straight line. So this is the disadvantage of supine position, and in lateral position as well as the prone position, the distal locking is done from the posterior surface, which is flat. So the entry hole, finding the entry point for the distal locking is easy because the surface is the flat, but it is uncomfortable position for anesthesia point of view, and the surgeons depends on the surgeon's choice. So I do use supine position for all my interlocking nails. Number 3 controversy is because it is non-weight bearing bone. So one screw distal and one screw proximal is sufficient, but I use 2 screw distal and 2 screw proximal because the 2 is always better than 1, always stronger than 1. If it is just like the 2 kidney present in human body, if one fails, others start working. So, and 2 engines in the aeroplane, one engine fails, the other start working automatically. So if one screw is not working, then the other screw will do its work. So the fixation is better by 2 screw proximal and 2 screw distal. So friends, these are the advantages of the long nailing over the plating of the humerus, and these are the myths, and these are the controversies whether 2 screws should be put proximal as well as the distal, what position should be used in this talk, and let us get tuned for the next video and subscribe my channel for more update on orthopedic surgery and insight.
Design the perfect voice for your brand with 11 Labs. Change the way.
ये है मिस्टर प्रशांत कुमार जो असम से आए हैं। उनके दाहिने कूल्हे का एक्सरे पिक्चर जैसा कि आप देख सकते हैं काफ़ी डिफॉर्म्ड हो गया है और एक दूसरे में चिपक गया है। कूल्हे का हड्डी कूल्हे का गोला कप में चिपक गया है और काफ़ी हड्डी बन गया है उनके। इसके कारण काफ़ी रेस्ट्रिक्शन मूवमेंट में उनको हो रहा था, वे ठीक से बैठ भी नहीं पाते थे कुर्सी पर। ये है एक्सरे पिक्चर, टोटल कुल्ला उनका बदल दिया गया है ऑर्थो सर्जिकल केयर सेंटर में, और 10 दिन के बाद वो वॉकर पे चल रहे हैं और फिर सीढ़ियों से उतर रहे हैं। इसमें ध्यान ये रखना पड़ता है कि उतरते समय पहले प्रेशर वाले पैर खुला को बदला गया है, उसको पैर रखना, उस पैर को रखना है, उसके बाद अच्छे पैर को रखना है, और चढ़ते समय पहले अच्छे पैर को ऊपर रखना है, उसके बाद जिसमें कूल्हा को बदला गया है उसको रखना है। ये अब ऑपरेशन के बाद ये कुर्सी पर बैठ सकते हैं, इवन लो चेयर्स पे भी बैठ सकते हैं और काफ़ी कंफर्टेबल और पेनलेस मूवमेंट अपनी ज्वाइंट आप देख सकते हैं किस तरह से खुद खड़े हो जा रहे हैं। लो चेयर पर आराम
पांडे जी को बुलाइए तो पांडे जी पूछिए तो